All right, welcome back to the second session of the conference. This section is dedicated to colon cancer screening in the community. And we have the pleasure of introducing our first speaker, Marilyn Fraser-White. Could you come to the podium, please? I will say a few words about Marilyn. She's the Deputy Director of the Arthur Ashe Institute for Urban Health and assistant professor of medicine in my department. She's also the Director of the Community Core for the Brooklyn Health Disparities Center. Welcome and thank you for joining us today.
Thank you. Well, good morning, everyone. So just to give you a little bit about a background, I think Dr. Salfu might have mentioned this before, but I'm also affiliated with the Brooklyn Health Disparities Center. And the center is a unique partnership in that it combines a community-based organization, an academic institution, and then the government entity, which is the Office of the Brooklyn Borough President. And I just wanted to give you this context in terms of some of the work that we'll describe today. So the Arthur Ashe Institute, for those that do not know about us, the institute was founded in 1992 by Arthur Ashe himself, just before he passed away. And we go out into the community and we do a lot of health education, health promotion in non-traditional settings. So that would set the basis of some of the work that I am going to be describing. And I know that you might have seen this before, but the reason why we're talking about colorectal cancer, we know that 1 in 3 adults between the ages of 50 and 75 years old are not getting tested as recommended. And so we need to improve our screening rates. And how do we do that within the community? And that's some of the things that I'll mention today. We know that those that are less likely to get tested are Latinos or Hispanics, American Indians or Alaska Natives, those that are part of a rural population, those 50 to 64 years old, and those that are low education and have lower income. We also know that African Americans, they have high incidence of colorectal cancer and high incidence and mortality. And we know that this is preventable. If we are screened early, that things can be detected and things can be treated. The screening rates for African Americans are quite low. And blacks are less likely to have a diagnostic colonoscopy after an abnormal screen. New York City has done, I guess, well in some sense in terms of reducing the disparities when you look at screening rates for colonoscopies. The disparities among races has kind of decreased quite a bit over the years if you look from 2003 to 2013. However, still there are disparities in mortality, and those continue to persist. So how do we not only screen people, but how do we get them into treatment? So this is a quote that I really like a lot. Arthur Ashe once said, "To achieve greatness, start where you are, use what you have, and do what you can." So starting where we are in New York. We are looking at Brooklyn specifically. We have estimated new cases of colorectal cancer for 2016 projected as being over 8,000. Deaths from colorectal cancer at over 2,000. We have screened a lot when you think of New York City. The screening rates compared to the rest of the US, I think we are ranked 11th in screening. Our risk factors when we look at Brooklyn, when we look at East Flatbush, where we are currently now, some of the risk factors such as obesity and diabetes in East Flatbush is 30% and 12% respectively compared to 24% or 10% in New York City. So using what we have. For those that are not familiar with Brooklyn, if you were to walk around some of the blocks over here, you know that we have a lot of churches on our blocks, we have a lot of beauty salons, we have a lot of barbershops. So non-traditional settings, they're there, and using those settings to inform the community. So I'll talk a little bit, the first approach I'll talk about is utilizing a colorectal cancer curriculum for stylists and developing a colorectal cancer curriculum to reach stylists with colorectal cancer messages. You may ask, why stylists? And so women frequently go to the salon. Some of us go more often than others. Hair salons are community information centers. Customers feel comfortable within their salons. They talk to their stylists about pretty much everything, things that they may not talk to their doctors about. And most women may have a stylist, but may not have a primary care physician. And stylists work close enough to their clients so that they can talk privately. They're just a few inches away from your ear when they're with you. And so those present the opportunities that you can have those conversations regarding health. So we collaborated with Columbia and LIU as part of a U54 grant to develop a curriculum for stylists and to just utilize the natural occurring conversation and social support that hairstylists provide to African American women in the community to encourage women to engage in colorectal protective behaviors. And this was funded by the National Institutes of Health. And in this study, we developed a needs assessment survey and to look at colorectal cancer knowledge, attitudes, and behaviors, also screening, education preferences, communication styles, how people talk to each other, what were the ways in which they received information. And we went out into various neighborhoods in Brooklyn. So the neighborhoods are listed up there, East Flatbush, Bedford-Stuyvesant, combined with Crown Heights and East New York. And we recruited stylists and customers from various Brooklyn salons. And we conducted a needs assessment with 114 individuals, or African American or Afro-Caribbean participants. And this is just a breakdown of those participants. As you'll note, we have a really great age distribution, and we have over 60% of those that were participated in this study were in the ages that you really need to present a message about screening to. Something that was really interesting when we asked customers about should their stylist confine their conversation just to hairstyling. Some customers said that yes, that they should confine their conversations just to that, because some customers felt as though when they went into the salon, they just want to do their hair. They don't want to hear anything else. But 66% thought that the salon was a good place to discuss health issues. Likewise, the stylists thought that 84% of them, a majority of them, thought that it was a good place to discuss health issues. Other things that may not be as alarming, but it's interesting as well, that the younger women thought that colorectal cancer screening was more embarrassing, and they might not have wanted to participate in that or think that they needed to even encourage people to participate. They understood that it was probably more embarrassing to talk about. And then the young women thought that stylists should talk pretty much about everything, so they didn't mind that. Those that were more educated, the college-educated population, which was about 30% of our sample size, they felt that they were able to identify correctly like colonoscopy being the most effective method. Also, the less educated women were more likely to think that the salon was a good place to discuss health issues. And if we look at what we talked about before in terms of risk factors of developing colorectal cancer and risk factors in terms of screening, the lower screening rates were among those that were less educated. And if this group is telling us that, okay, the salon is a good place to present that message, then why not introduce screening and stress screening among that population? So I'll just go through a few slides in terms of the curriculum that we developed. It was important to tell people what colorectal cancer was, define that for them, let them see what polyp looked like, describe that. Also the anatomy of the colon that we take for granted. I think sometimes being in health, we think that our patients may know where the colon is, they know where the large intestines are, but then we need to show them in respect to in relation to the other parts of the body as well. And the kinds of tests that are available, people may hear about tests, but they didn't know what those tests were and what are available for them to use. So one of the things that we did was we went through all the tests that are available and explained it to them, and if anyone had any questions, we encouraged that. And then finally we told women to do something. Like, they can make a difference to save African American women. And beauty salons are the perfect place to spread the word about promoting good health. We encourage them to find a regular doctor to visit, to get their checkups and get screened. And not just screened for colorectal cancer, but screening that's age appropriate for different women. So this was what we did with the women, and then we said, okay, we need to do something for the men and do something within barbershops. So we developed the Mr. B project, which was conducted in collaboration with NYU. The PI on this project was Dr. Joseph Ravenel. And we conducted this project in barbershops and churches across New York City. And again, the goal was to increase colorectal cancer screening. So some of the contributing factors that we know about already, that black men are less likely to have screening colonoscopies before age 65, and blacks are less likely to have diagnostic colonoscopy after getting an abnormal screen. And again, why barbers? There's a history of barbershops. For those that know a little bit about barbershops were used originally as centers for surgery. They were used as places for dentistry, and they were used as community centers. So talking to barbers about this history was very engaging for them, that they realized, like, yes, you know, we were the center of the community, and we are the center now, but for different reasons. And how do we utilize that to spread and bring forth a message? And access. The barbers have access to their customers. Their customers think of them as good listeners, sometimes as their own therapists. And so let's utilize these characteristics and these traits to incorporate messages, health messages that can benefit the community. So in the Mr. B project, we screened over 4,000 men and then decided those that were eligible. And the eligibility were basically, eligibility criteria were for men that were over the age of 50, African American men, and men who had not received a colonoscopy within 10 years. And so these men weren't screened in over 10 years, or some might not have ever been screened. And so just to get an idea of what that population looked like, the mean age was 55. Most of those were born within the U.S. The other percentage were people from the Caribbean, foreign born. And then you see the distribution in terms of education and also employment. When we look at people that were out of work for longer than 1 year, 34.8%. The income, the average one was $17,000. So you're looking at a real low-income population. And in this study, we linked people to navigators so that they can not only enroll in, so somebody can guide them to get their screenings done. And we found out that those that received patient navigation were more than twice as likely to get screened as those that didn't get navigation. And the screening rates were similar to those from past studies as well. And the intervention was equally effective for those with no insurance or those with low health literacy. So in thinking about our next steps, we would like to continue the education to improve colorectal cancer screening. It's great to educate people about getting screening, but also the major thing is linking people to services, making sure that people follow through on those things. We'll be partnering with the American Cancer Society, and we have joined the national effort to get 80% of adults over the age of 50 to get regularly tested for colon cancer by 2018. And you'll hear a little bit more about this, I'm sure, from the American Cancer Society. And with this goal in mind, with the 80% by 2018, we hope that 277,000 cases or 203,000 colorectal cancer deaths will be prevented by 2030. So in conclusion, starting where you are, you have a community, maybe a regional or maybe national, and starting locally in where you are, identifying those resources that are available, those natural resources within your community, and finding out how you can best leverage those. If we're going out into the community, you have community settings that are in place that we can leverage. We have lay health advocates that are within the community, community leaders that can be engaged to spread the message and to bring the word to others, and do what you can. So we want to educate, and not only educate, but link people to services, treat, and ultimately improve health outcomes. So thank you for your time, and if you have any questions, I guess towards the end. Okay.
Thank you very much. This was very nice. So now we turn to the health department. I invite Ms. Elise Collins to talk to us on addressing barriers to colorectal cancer screening, the New York State Health Department perspective. Thank you for coming.
Well, thank you so much for having me here today, and I did want to say, I can't believe I'm the first person to say it, but it's Colorectal Cancer Awareness Month. Today is National Dress in Blue Day, so I like seeing all the blue around here, and ACS is here handing out pins. If you don't have blue on, please stop by their table and grab yourself one. So I'm here to talk about addressing barriers to colorectal cancer screening. I'm going to focus on the New York State Department of Health interventions. So I'll talk a little bit about colorectal cancer in New York State, although I'll speed through a bunch of slides because they've already been covered, and then start talking about some effective interventions that have occurred in New York State in community clinical linkages as well as health systems approaches. So colorectal cancer in New York State is the second leading cause of cancer or death. We've heard this. It can be treated. It can often be cured when it's found early and treated through screening. It can be prevented when polyps are found before becoming cancerous. Evidence-based interventions can increase screening rates across all populations. I know we're here to talk about disparities, but the interventions work in both minority and other populations and across everyone. And health systems and provider partners really play if not the key role. Provider recommendations for screening are essential to getting people screened. So we've already seen data in New York State. New York City and New York State data in terms of incidence and mortality is very similar. We've seen these slides as well in terms of trends by race. So I'll just speed through those and get over to screening. So in terms of colorectal cancer screening, a lot of progress was made over the past 15 years, but as you can see, it's been leveling off in recent years, and that's one reason why the 80% by 2018 campaign has been implemented. There's just some visuals of screening rates around the state and the city, and this is all self-report behavioral risk factor surveillance system data, so take that as you will. But you can see that rates of screening are not equal across the state or the city and metro area. As you just heard, about 1 in 3 adults between the ages of 50 and 75 are not getting tested as recommended, and in New York State, that means about 1.2 million eligible New Yorkers have never been tested. And you can see here, it's about 7.5% of people who have been screened, but they're not up to date with screening. So those are sort of low-hanging fruit that we could really increase our screening rate in New York State if we get to them. So who are the unscreened in New York State? While of course there are disparities across races, what we really find is that that most of the unscreened actually note having a healthcare provider, and about 2/3 note that they have been to the doctor's office in the past 12 months. So there's a real opportunity to reach these people as they're already part of the healthcare system. This is statewide data, but similar analysis with the New York City Department of Health and Mental Hygiene found very similar numbers. Again, here's screening rates via race. They're not, again, too different, but it's really that other factors, household income, insurance status, and educational status really appear to be the higher predictors of screening status. And here's that data. Income and education appear to be the largest drivers of screening disparity in New York State, at least, again, from the behavioral risk factor surveillance system data. So what are our opportunities? Although New York State is one of the top states in terms of screening rates, in the top third of states, we have work to do, especially in reaching disparate populations. Their healthcare landscape has changed and really made it a very opportune time to address colorectal cancer screening. So New Yorkers have access to affordable health care. Screening tests are covered by health insurance. An evidence base exists for what works to get people screened. There are a lot of tools and resources available, and partners all over the state are working and are committing to reaching the 80% goal. So the two areas that I'm going to focus on today are community clinical linkages and health systems approaches. Community clinical linkages, that's a reciprocal relationship between the community and the healthcare system, where the healthcare system supports individuals to maintain health in the community, and then the community supports individuals to utilize the healthcare system. In New York State, we run the Cancer Services Program, the goal of which is to increase the proportion of women and men who are up to date with screening for breast, cervical, and colorectal cancer screening. We implement our program through a network of contractors around the state who work with clinical and community-based partners to find and enroll eligible New Yorkers. In the last 10 years, we have screened about 576,000 people statewide, and that's breast, cervical, and colorectal cancer screening. So this is our eligible population. We implement our program based on, it's a risk-based program, so specifically for colorectal cancer, what we do is for those at average risk for colorectal cancer, we offer them fecal tests every year. We focus on low-income populations. They have to be less than 250% above the federal poverty guideline, and uninsured or underinsured, meaning unable to afford their co-pays for cancer screening. It's just some data about our clients screened by race and ethnicity. And we, as I mentioned earlier, lack of insurance does kind of correlate with low colorectal cancer screening. So we at the CSP are not experts, but we have spent a long time trying to find the uninsured. And we particularly having a struggle with that with implementation of the Affordable Care Act, which is fantastic, but it does mean the uninsured are harder to find. So what are the characteristics of the remaining uninsured? Not engaged in healthcare, they're low income. We need to know about these people to be able to find them. They are a difficult population to find and work with. They're not engaged in healthcare, and healthcare is not a priority. The population will likely not be found in clinical settings except urgent care. They're most likely to be focused on immediate needs, jobs, food, and housing issues, and broad outreach events like media or tabling at community events are really not going to find and engage this population. So activities like what Marilyn had just discussed in terms of finding this population where they are key. So we do still work with clinical providers to try to find these clients. We do in-reach in the healthcare setting. We work with FQHCs who take self-pay clients and try to build relationships there. We do outreach events and work with community partners. They're needed to promote the program, provide transportation, cover ancillary services that we can't fund, incentives for screening. We do education, and again, try to do educational sessions at locations where our clients may be. Just some successful interventions within the Cancer Services Program. Our Manhattan contractor regularly teams up with Univision TV and the American Cancer Society to advertise and promote screening. They run ads, have educational sessions, segments during news hours. They have one Saturday, I believe it's a month, but I'm not exactly sure of the frequency. They're on site at Columbia Presbyterian Breast Center, and they, really promote these activities within the Spanish-speaking population. They also employ a Spanish-speaking outreach worker and work with the Gay and Lesbian Community Center to increase screening within that community. They bring the Project Renewal Mammo van to that center to offer easy and community-friendly cancer screening. In Queens, our Queens contractor runs events with Korean Community Services, the Queens Library System, HealthLink, and the ACS Asian Initiative. It's a day-long event with Korean and Chinese doctors who give educational sessions. There's Cancer Services Program staff there on site offering appointments for breast and cervical screening and doing fit kit distribution. They also have developed an educational brochure that's available in 10 of the most popular languages in the borough. The brochures have photos chosen by members of the community that they feel are representative of them. The provider contact information is on it, and each has a language line service for any client that may call. In Suffolk, our Suffolk contractor works with the Consulate of El Salvador to bring in El Salvadorans who are living in Suffolk. more than 50% of our cancer services program clients in Suffolk County are undocumented, and the vast majority are from El Salvador and other Central American countries. We also do ancillary community activities outside of the cancer services program to try to make it easier for people to get screened. We have an initiative right now that's trying to promote paid time off policies for cancer screening. So, you get 4 hours of paid time off for a mammogram, up to 8 hours for a colonoscopy, et cetera. Again, trying to reduce some barriers to screening. I also want to make a little plug. We have the Medicaid Cancer Treatment Program here in New York State that is unique in that we provide a Medicaid for eligible persons who are in need of treatment for breast, cervical, colorectal, or prostate cancer and some precancerous conditions. Once an individual is enrolled in the MCTP program, they have full Medicaid coverage provided for a year and then can recertify for the length of their treatment. Enrollees must receive services from a Medicaid-enrolled provider, but this is really a key program to support the uninsured in getting their cancer treatment in New York State. I'm going to talk now more about some health systems approaches to increasing screening. In order to increase screening in the health system, we really do need more organized approaches to screening. Engaging and working with health systems to implement evidence-based interventions, like using reminder systems, has the potential to reach a huge number of people. And currently, within most health systems, it's an opportunistic approach to screening, meaning someone's there in front of you, you recommend screening, which is fantastic. But an organized approach has the opportunity to really reach your entire patient panel. So from the state perspective, we focus on evidence-based interventions, and generally, those fall under the Guide to Community Preventive Services. The Community Guide, if you're not familiar, it does help find interventions, programs, and policies that improve the health and prevent disease. Interventions are selected through systematic reviews and try to answer the questions of which program and policy interventions have been proven effective, what might they cost, and what's the likely return on investment. So for cancer, they have this handy chart for breast, cervical, and colorectal that talks about what has evidence behind it and what has insufficient evidence to recommend for each type of cancer. So for client-oriented activities, client reminders, which could be postcards, they could be auto calls, texts, email reminders. We have had significant success within the cancer services program with automated phone calls across both the uninsured and insured population. We did a project over 2 years that saw a 5% increase in screening among the people who had received the reminder calls. And again, just a simple call saying, you're due for colorectal cancer screening. A second, small media. Again, it's key to target your media to your population, but these are brochures, just posters in your office, normalizing screening. There are free resources available from the Department of Health. You can order them from our website. There's also a fantastic system called the Make It Your Own system, or MEO. You can go online, it's meoworks.org, and in that system you can develop your own postcards, brochures, flyers with evidence-tested interventions. There are free photos on there. You could upload your logo and then print them out. Again, it's mioworks.org, and really tailor. They have right now, I think, only English and Spanish, although I believe they're working on additional languages. One-on-one education, again, that's key, and that can be done by the provider. That can be done by other office staff at the practice. When someone's getting checked in, they can be handed a brochure. It doesn't have to necessarily be the practitioner. We also, reducing structural barriers is key for colorectal cancer screening. So these are reduction of non-economic burdens or obstacles that can make it difficult for people to access screening. Some interventions that are designed to reduce these barriers are patient navigation. And in New York City, there's a great colonoscopy patient navigation program, but that program only identifies clients when they are referred to colonoscopy. There are other patient navigation programs out there. I'll talk about another one in a moment that actually navigate clients from identification of the need for screening, not just when they're referred to colonoscopy. Also reducing structural barriers would be supporting the availability of screenings in locations outside of the doctor's office. So for colorectal cancer screening, that probably means fecal test kit distribution, whether it's a mailing of fit kits or whether in combination with a mammography van, you hand out fit kits. That can really be is a successful strategy. Support transportation to screening. Again, for colonoscopy, transportation can be a barrier. Modifying hours of operation, having weekend hours, evening hours, having screening events. Again, it's really difficult for people to take time off of work, particularly colonoscopy. You need more than a day off, really, for the prep. Promoting the Affordable Care Act screening benefits. Many people don't know that colorectal cancer screening is a covered benefit without copay or cost sharing. So that's a huge benefit. And then you can eliminate and simplify administrative procedures such as providing scheduling assistance, again, patient navigation support, transportation support, translation services, limiting the number of clinic visits. I know in New York City you've got the direct endoscopic referral system here, which is great. That's when the primary care and endoscopy set up an agreement to refer clients directly to their colonoscopy without having to go to their GI consult. In addition, for fecal test kit distribution, if you can mail kits to clients' houses and they can mail them to the lab, that's been shown to be effective. I know there was one FQHC that we worked with in the city who you had to come into the clinic to pick up your kit, and then you had to come into the clinic to drop it off. And that's a huge barrier. That's 2 clinic visits for a kit that can be done at home. So again, just looking at ways to reduce some of those barriers. In terms of healthcare system and provider-focused interventions, provider assessment and feedback is evidence-based. These interventions both evaluate performance in delivering or offering screening to your clients and then present you with information about your performance. So this can describe the performance of a group of providers or individual providers and can be compared to a goal or a standard. Basically, just assess how many patients receive screening services and give you feedback on how you're doing with your patient panel. And then provider reminders, I'm sure you're familiar with those if you're in practice. That's all those boxes that pop up on your electronic medical record before you can go on and do anything else in there. But they'll inform you when a patient is due or overdue for screening services. They can be through your EMR. They can also just be added to patient charts. Your EMR has this capability to give you provider reminders. It's just a matter of determining how to use it. And then making sure that screening data is entered in your system in a consistent way across the practice and in a way that the system can report back to you. We certainly know that there have been concerns with electronic medical records that aren't capturing data or screening data is not captured in reportable fields. So once you get over the barrier of setting up your system to report on your data, the assessment, feedback, and using that data to contact clients can be successful. So 2 successful health systems interventions I'm just going to touch on, patient navigation and federally qualified healthcare centers. We did a project with the Charles B. Wang Community Health Center. It was based on a cancer registry analysis that back in 2010 identified higher than expected incidence of colorectal cancer in Chinatown and in Flushing. We worked with Charles B. Wang to implement navigators who worked from identification. They worked with their IT department to pull lists of clients due for colorectal cancer screening, called them, provided education, worked with them to reduce barriers to screening and get them in, and then get them all the way through to screening and diagnostics and treatment as necessary. From July of 2012 through May of 2015, we had 1.5 patient navigators who contacted a total of 3,855 patients. 69.3% had completed, by the end of the project, completed at least 1 colorectal cancer screening test. Through a quirk of the data, some actually completed both a colonoscopy and fecal test. There were about 1,176 patients who refused screening or were lost to follow-up. But the patients who were screened were predominantly female, Asian Americans, had non-English as their preferred language, mostly Cantonese or Mandarin. They lived in Manhattan, Brooklyn, and Queens, and were uninsured or insured by Medicaid. Over this time, the overall colorectal cancer screening rate at Charles B. Wang increased from 56% to 60%. So we consider this a huge success. And overall, the program received really positive feedback, both inside the clinic and from patients and various stakeholders. And based on available data, it was likely cost effective. We're still doing some analysis on that. And then Kaiser Permanente has done some great work, both with mailing fecal tests to their patient panel, but they've also done some interesting work at reducing disparities. In 2010, they began work to reduce disparities between whites and Latinos with the goal of eliminating the gap by 2017. So what they did was made sure all instructional and educational materials were available in Spanish. They had bilingual signage to promote screening. They developed messaging that they found resonated with Latino patients. They promoted success stories from individuals, and they used promotories, who are Spanish-speaking health educators. They also created pictorial instructions for completion of FIT, which could be understood by speakers of any language, and those have been successful and are actually available online. We've used them in New York State. And although racial disparities in screening do still exist, the gap with their patient panel is starting to close. In 2010, there was a 6.7% gap between whites and Latinos, and in 2014, only a 3.3% gap, so I would consider that a success. In closing, I just want to again give some more plugs for additional resources. The National Colorectal Cancer Roundtable website is a fantastic resource, both the 80% by 2018 tab and the Tools and Resources tab. They've got information on effective messaging to increase colorectal cancer screening, as well as tools for how you can implement some evidence-based interventions in practice to increase screening. And then for Colorectal Cancer Awareness Month, there's a Public Health Live event, which is through the School of Public Health in Albany, and we'll be doing a seminar on increasing colorectal cancer screening, what's been effective in practice. And Dr. Dan Napolitano of the Community Health Care Network, Dr. Joseph Ravenel will be a Roland, Marilyn spoke about before. Dr. Kevin Vasella from in Rochester area will talk about what he's done with colonoscopy and FIT, offering screening options. So I highly recommend that you join into that. Thank you very much.
Thank you very much, Ms. Collins. So the next speaker is Dr. Alvaro Carrasco. So we are now going to hear from the American Cancer Society and hear what the perspective from that angle is. Thank you for coming.
Thank you for inviting me. Good morning. It's good to be here in Brooklyn. I came from Albany, New York, to see snow in Brooklyn because we have outdoor snow almost this season in Albany. I used to visit this campus often. I worked 25 years in HIV/AIDS, and the last 5 years I've been working with cancer, with the American Cancer Society, overseeing our cancer control efforts in both New York and New Jersey. So I want to speak about the importance of partnerships, which is nothing new, but I think I want to encourage you to think beyond what has been traditional collaboration and partnerships. And I think to make an impact in this area of colorectal cancer, we need to break silos and look beyond just the clinical setting or the lab setting, going to the communities, going to the corporate sector, and also encourage all the forces available to move the mark. I'm assuming that this moves. Okay, all right, good. Yes, thank you. I need to be trained. So I think, I'm going to skip this slides because we have done enough of this already, and you had seen these slides. So, but let me just continue on the issue of the partnerships. If you look at, the trends in science is to look at through disciplines and across fields and really break down silos and work together to achieve our goals. This is also marked by, for example, currently the influence of technology that is changing medical care, medical practice, medical research, and that we need to join with other disciplines in order to move forward as everything becomes more complicated and more segmented. So one of the examples of this is the National Colorectal Cancer Roundtable that had been mentioned before, which was funded or started by CDC and the American Cancer Society, which includes now hundreds of organizations across the country, listed over there, the type of organizations, including the federal government, the state government, and professional organizations, et cetera, in an effort to advance colorectal cancer screening. As we all know, there is no discussion, no debate about the importance of screening and the ability to prevent not only death, but also cancers through appropriate screening. So the current chair of the task force, or co-chair of the chair of the task force, I'm sorry, is Richard Wender, who is a family physician originally from Jefferson. He was the chair of family medicine, and now is the chief cancer control officer of the American Cancer Society. So the organization has set up this 80 by 2018 campaign with the hope of achieving around 200 cancers prevented, 200 deaths prevented, 200,000 deaths prevented by the year 2030. And we are trying to increase the number of organizations, not only in the healthcare sector, but also in the corporate sector, to encourage employees to be screened, to have a baseline of what percentage of employees are being screened. We're approaching communities, healthcare partners, anybody who is willing to support this. So today we're going to be, some of the organizations, SUNY, Arthur Ashe, et cetera, are going to be signing the pledge, but I think that we should not be just the act of signing the pledge, so we need to translate that into action and partner with our primary care friends and colleagues to really expand screening. Just to highlight some examples of partnerships and collaborations, in New York City, I think most of you might be familiar with the C5, which was started in 2003 in New York City by Tom Frieden, who is right now the CDC director, and has been focused on colonoscopy. And you already saw the importance, because you already saw this. By the way, these are the partners and stakeholders, ranging from the city health departments to GI, the American College of Gynecology and Obstetrics, the New York State Department of Health, Center for Immigrant Health, many players and stakeholders in this coalition that has achieved significant hallmarks, because, as you saw before, eliminations of virtual elimination based on surveys of difference in screening among racial and ethnic groups. I also want to highlight the New York State Cancer Consortium, which is a statewide organization convened by a group of people funded by CDC, by the New York State Department of Health, the New York City Department of Health, and the American Cancer Society, as well as the Chicanes, which is the state network of federally qualified health centers, are working together to increase colorectal cancer screening in New York State with the aim of helping to move the state to 80 by 2018. By the way, Massachusetts, our neighbor state, is the one that is closer to achieving the goal, because they're in the upper 70s. Just an example of the type of collaboration that we need. We need community mobilization. We need patients to be educated, and the public to be educated, so they can come to the primary care provider's office and demand or request that he or she be screened. So we had this event in Buffalo on Monday, in which we had the Buffalo mayor, Byron Brown, there on the right side on the left side of the guy with the helmet, and Rich Wender of the Cancer Society, and all the major health systems in Buffalo, 3 healthcare plans, and advocacy organizations, the county health department, all committing to take local action for the systems to improve colorectal cancer screening in Buffalo, Erie County, and help us reach 80 by 2018. So a little bit more about something that was described already, which is the project that Joe Ravenel from NYU has been, with funding from CDC and also funding from NCI, has been conducting to increase colorectal cancer screening through non-traditional ways, going to barbershops in the 5 boroughs. I think Dr. Fraser already mentioned this and provided information, but the importance of patient navigation in increasing colorectal cancer screening and low literacy, low education, uninsured individuals. I just wanted to highlight that, or mention that there is a small primary care clinic in Maine who's published an article this week this month, I'm sorry, that they went from 40% 3 years ago, and with the use of community health workers or patient navigation, we're able to reach 82% of colon cancer screening rate in a space of 3 years. So that's commendable and it's achievable. I think it's important that we try to aim high and try to get to a goal that is a little bit distant and hard to reach so we can make a significant movement. So anyway, Joe Ravenel is collaborating with us and with many partners across the city to increase screening among the underserved. I wanted to, again, thanks for the opportunity to be here with you, and hopefully we have a wonderful end of the day with the closing in the afternoon session. Thank you so much.
Thank you very much, Dr. Carrasco. So now we move to DSRIP. How many of you know about DSRIP? Raise your hands, let's see. All right, DSRIP stands for Delivery System Reform Incentive Payment. It's the New York thing to fix the healthcare system. And so we have the pleasure of having Nicole Jordan Martin, who is the Senior SVP for the and Hub Executive Director for One City Health, which is one of the largest PPSs in New York State. So we are really happy to have you here to talk to us on DSRIP implications for the CBOs and also colon cancer screening. Thank you for coming.
Good morning, everyone. Thank you for having me here, and it was actually great that I was here from the very beginning because I learned quite a bit about the biological and clinical presentation of colon cancer on patients. And so my talk today is to talk about community partners under this new way of doing business called DSRIP. And they're very important because they also deal with a lot of the impact of the biological and clinical presentation. They deal with that at the community level in terms of providing social and family support services. So for today, I'd like to share with you a bit more about what DSRIP is and to talk a little bit about DSRIP as an enabler of chronic disease prevention and looking particularly at prevention of colon cancer, the role that community partners can play in chronic disease prevention, the opportunities for community partners in colon cancer prevention in particular, and share with you a scenario of a particular potential patient or client that may present and how community partners can impact that person's health, and then answer any questions that you may have. So what is DSRIP? So many of you have heard this acronym for a while now. I think for many people it's still very fuzzy about what it is. So officially, DSRIP emanated directly from the Affordable Care Act and was mandated by the Centers for Medicaid and Medicare Services. And the impetus for DSRIP is really nationally, and then New York mirroring what's happened nationally and why we need to change the way that we approach healthcare delivery. Is pretty much the same. So nationally, we have the most expensive healthcare program in the world, and especially compared to a lot of our developed counterpart countries. And in addition to having the most expensive program, we still have not delivered on the 1963 promise before the United Nations, where we stood with 72 other countries and promised to provide access to health care for every man, woman, and child in this country. And in addition to spending all of the money that we do, which is significantly more than many of our developed counterparts, we are not getting the so-called bang for the buck. So we're not really moving the needle on outcomes, and again, creating equitable and affordable access. So in comes New York, mirroring that situation, most expensive Medicaid program in the country, Again, very fragmented silos of care, and not moving the needle on the outcomes, and in particular, for many populations that all of us serve and who we know are impacted by a number of disparities. So District is really a 5-year initiative. I know it's called a program. There's program at the end of it. But I really want you to think about it as a 5-year opportunity to restructure our delivery system in the state of New York. And that 5-year period commenced on April 1st of 2015 and ends March 31st of 2020. It's a $6.42 billion initiative that came out of Governor Cuomo's efforts to redesign Medicaid in the state of New York, with this being the largest component of that Medicaid redesign effort. And it's targeted to public and safety net providers who, again, are tasked with transforming healthcare delivery in the state. The goals are to transform the safety net system, reduce avoidable hospital use by 25%, which includes admissions and readmissions. And that 25% is a statewide goal. It's not limited to any one particular performing provider system. It's to pursue the concurrently pursue the triple aim of better care, improved outcomes, and reduce costs, and ensure that we have sustainability as we transform the delivery system beyond this 5-year period, and that sustainability being achieved through managed care payment reform. The key components for District are statewide funding for public hospitals and safety net providers, which is a very important component, and kicked off with something called the Interim Access Fund, which really provided sort of emergency money to keep a number of hospitals in particular who are on the brink of becoming extinct and disappearing from communities that really, really need them, keeping them alive while long-term planning for their sustainability and continued service to those communities. The requirements for who participate in District, this one in particular I really liked. It was really forcing marriages among many different partner and provider types. And so you had to come forward as a coalition of partners in order to be designated by the State Department of Health as what's called a performing provider system. The projects that the District initiative focuses on came from a menu that was provided by, again, CMS and the New York State Department of Health in consultation with two key other state agencies, the Office of Alcohol and Substance Abuse Services and the Office of Mental Health. And the projects selected by a particular PPS really needed to be informed about what the community needs assessment for their particular geographic area, also identified as important needs for those communities. Payment is based on performance, so this is not a grant program. You have to do the work, and then based on your performance, and performance meaning primarily that you are moving the needle on health outcomes of the individuals that are being served under this initiative, you will be paid for that effort. And you also get some payment on a number of things that we call milestones. They're sentinel events or expectations around restructuring, working in partnership, and reporting progress to the state. So a performing provider system, as I said, is a coalition of partners, partners meaning providers, many types of providers, and then other community-based organizations who are coming together to work on this initiative. And again, working together to really address community healthcare needs and aligning ourselves as a group of stakeholders who are really tasked with looking at those needs and then designing interventions, services, programs to address those needs. It's also about building upon the projects that we've identified, and looking at how we align that work with existing work. So we're not trying to duplicate, but really align with existing work, and using this as an opportunity for what we know as best practices and success, and really expanding that and providing greater accesses to those things that we know that work to more of the population that we're serving. It's also about looking at particular subsets of the populations or areas of our communities identified as hotspots, or areas where we know there's significant needs, needs that either the community has informed us about, the federal government, such as healthcare provider shortage areas. In Brooklyn in particular, we have 9 primary care provider healthcare shortage areas, and we have 4 mental health provider shortage areas. Nationally, this is a crisis, certainly in New York City, and of course, Brooklyn is no exception. And it's about meeting commitments that we make in what we call our district project plan or implementation plan around what we said we would do to service the communities to move the needle on their health outcomes and to restructure and transform healthcare delivery in Brooklyn. Okay, so for One City Healt, which is one of 25 performing provider systems in the state of New York and 9 in New York City, and one of 5 in Brooklyn, we are a partnership of 220 organizations, including New York City Health and Hospitals. New York City Health and Hospitals is our fiduciary and our largest partner in this performing provider system. But as you can see, the partners are all, community-based organizations, various institutions. And again, our agreement about being partners in this PPS is that we are coming together to form a local continuum of health and social services. We are representing and advocating as the voice of the patient. We're building effective and collaborative governance and management processes around how we work together and how we work in service to patients, their caregivers, families, and communities. And with our partners and patients, how we design and implement the approaches to improve population health. And of course, we're committing to ongoing continuous improvement in terms of looking at how we work together, how we design and deliver services. So the network for One City Healt, you can see representation by borough. In Brooklyn, we have the 4 acute care facilities, which include 3 New York City Health and Hospital facilities, and of course, this institution we're standing in SUNY Downstate Medical Center. You can see many partner types: primary care, outpatient behavioral health, long-term care, pharmacy, and then social services and community-based organizations is the largest subset of this partnership. The partnership for us across our 220 organizations represent about 1,100 sites and 12,000 providers. So we are the largest performing provider system in the state, and our potential earning capacity for this initiative is $1.2 billion over this 5-year period. Our projects that were selected were again informed by community needs, as well as the menu of projects that were selected by that were put forward for selection by CMS and the State Department of Health. And so while there's no particular project here that focuses on colorectal or colon cancer particularly, there are many projects here that focus on chronic diseases, of which colorectal cancer would be considered one of those. And so the common elements about doing this work together, this partnership of 220, is being patient-centered, identifying and making and stratifying the population that we're serving. So knowing who we are, who our patients are or our clients are, and understanding their needs and targeting them to interventions to address those needs. It's about community-based engagement and education, navigation and coordination across settings, cultural competence, information sharing within the partnership of 220, and with other partners outside of the 220. And it's about using evidence-based interventions as we approach, again, the population here in Brooklyn. So the way that Disrupt work is translated to the care continuum is it's heavily focused on strengthening primary care and behavioral health, supporting seamless care transitions, enhancing outreach and activation, and this one in particular targets individuals who are uninsured, and uninsured whether or not they're insurable or they're undocumented, and who may be insured but they're not utilizing their Medicaid benefits in particular in a very limited way, and primarily not demonstrating any connectivity to primary care. And it's also about ensuring robust and targeted care management. And so we highlight again the different types of partners that we have in our partnership of 220. And for today, I'm really focusing on community-based organizations and the role that they play, because again, they have a very, very critical role in all of this work. And in most instances are the first face of a healthcare encounter for many of the patients we serve and the clients, as they refer to them, that they serve. They also have the most trusting relationships. And again, I heard a couple of my colleagues mention that trusting relationship really comes from their perception of what's a priority in their life. And community-based organizations in particular are the first partners, if you will, who help address their perception of what their priorities are. So to talk a little bit about Disrupt as an enabler of chronic disease prevention for colon cancer, looking at primary prevention, which is modification of risk factors, secondary prevention, detection of disease in its earliest stage, and then tertiary prevention, disease management to prevent debilitating and costly complications. Again, if we look across the partnership of 220, we can see community-based partners in general and community-based organizations in particular have a role in all three types of prevention activities here. And so the key roles for community-based partners, and again, community-based organizations in particular, revolve around linkage to primary care, care management, and care management is the concept of wrapping around someone, looking at them as a whole person, assessing what their needs are, their medical health, their medical needs, their behavioral health needs, and their social and family support needs, and then really coming up with a plan to address those needs and link them to all the services that they require. A critical role around cultural competence and health literacy, and making sure that we address that in all of the work that we do around how we design and deliver services. And then activation and linkage to social and family support services, which is very critical for the clinical folks. We do, great job designing, interventions, and but we also need to understand that there's this person that appears in front of us in very episodic ways in clinical settings, emergency rooms, urgent care centers, the inpatient settings, even some of our ambulatory settings. They have a whole other component of their lives that we often are limited in addressing in those settings. And so activation particularly refers to not just the responsibility of a community-based organization to sort of identify and work with a patient or a client and their caregiver or family to link them to services, but it's also to teach that individual about their own self-management and what they need to do to be an active participant in their health care. So if we look at opportunities for community partners for prevention, looking at health promotion, which is a significant body of work that community-based organizations in particular have historically embraced. It's really around providing individual and group education, dissemination of educational media, and reminder mailings. Again, they're encountering this population. They have long-standing relationships and trusting relationships. They're providing a broad array of services. It just makes sense for them to use the opportunities when they have an individual in front of them to really incorporate screening, education around cancer screening, and actually facilitating the access to screening as needed. It's care management and coordination coordination. So someone with colon cancer would be considered an individual with chronic disease. And if they have another chronic disease, or they're also HIV positive or have a serious mental illness, they would be eligible for a statewide Medicaid care management initiative referred to as health homes. Or if they only had one chronic condition, they would be eligible for, under DSRIP, what is called health home at risk intervention. So these are individuals that we like to refer to as the worried well, meaning that they may have been doing pretty well, but they're gradually showing evidence or signs that health is declining, and so we want to impact that very early on by linking them to care management that may not be the same intensity that the health home care management initiative offers, but at least some intervention to begin to help them to identify and navigate and link to care management and care coordination services. And so as part of the linkage and navigation, it's important to know that community-based organizations, address structural barriers that impede linkage and that make navigation quite difficult, such as accessing screening services at convenient times, so just non-traditional hours, accessing screening in non-clinical settings. So again, we heard from a couple of my colleagues who preceded me in presenting about looking at non-traditional settings. We're seeing even in our partnership of 220 that there are opportunities to be more innovative about other kinds of partners that we need to engage. So other places that we know people are frequenting, gymnasiums, supermarkets, and so to really begin to think outside of what we traditionally know as our provider community and our community-based organization partners, and think a little more creatively about who else we can engage that are important to the population that we serve and who they trust for messaging. And accessing services because of a lack of transportation or providing reimbursement for transportation. A very, very important role is community-based organizations, their expertise in cultural competency and health literacy, and how we can leverage that to inform, again, access to prevention services for colon cancer screening. And so particularly expertise around more than just language and handicap access. Cultural competency and health literacy also really looks at age, ethnicity, race, culture, religion, disability, gender, and so really making sure that as we, again, think about design and delivery of services, that we're incorporating all of these factors into those designs. Expertise for development of educational media, again, because they're interacting more frequently with this population and interacting with them in a more intimate manner in many instances, and again, addressing their perception of what their priorities are, which more often than not don't include their health status. It's very important that, when we think about how we develop communication media for this population, to seek their expertise in that regard. And then also using their expertise to inform how we educate others about design and delivery of services, and others meaning not just providers, but other stakeholders, which may include regulatory bodies, other legal and advocacy bodies, just so that they're aware about some structural barriers that may involve some regulatory remediation or legal remediation to allow individuals to access services. And then partnerships with clinical providers. So we know, again, that community-based organizations are the hubs, again, and many of them serve as centers, community centers in the communities that they serve. So bringing the services into those settings is an important consideration. The notion of one-stop shop is very, very important, in particular for the population that we're focused on for DSRIP, which is the Medicaid population. We know this is a population that has significant socioeconomic barriers. They have psychosocial barriers, and we know that they have limited education, they have other cultural issues that impede their ability to navigate and advocate and access services. So one-stop shop is very important. The more you can provide in a single setting, the likely you are to be able to retain relationships with those individuals and continue to leverage the trust and existing relationships to provide access to other services. And then prioritization of appointments to facilitate screening. So partnerships are not just about informing and educating folks. If we don't create the capacity and access to the actual screening and care and treatment and support services, then we're doing ourselves and our patients and clients a disservice. So it's also about working together to make sure that when you have screened or identify and you're making a referral and linking, that is being prioritized and the person isn't going to screen and then wait 3 months to see a provider to actually be evaluated for treatment. So to give you a taste of how working together in the district can facilitate this kind of impact on someone's health is I want to introduce you to Marcus. So Marcus is a 55-year-old male. He speaks limited conversational English. He shares an apartment with his 2 elementary school-age grandchildren, whose mother lives and works in New Jersey. He comes into a community-based organization seeking help with getting Social Security benefits. He states that he last worked 3 years ago because he developed heart problems and high blood pressure. He also states that he's not able to visit his doctor when he should because he has to care for his grandchildren before and after school. From the CBO assessing his needs, they learned the following. He has a family history of colon cancer and can't recall if he has ever been screened. His last visit to his primary care doctor was 9 months ago. His health insurance status is unknown. His sole income is from his daughter, who gives him $125 weekly to care for his grandchildren. He takes blood pressure pill every now and then. So a question for us as we work together as a partnership of 220 is how can we help him improve his health? So if we worked as a partnership of 220, again with community-based organizations playing a very critical role, we would be wrapping around Marcus so that his experience is an integrated care continuum where we're all working to address his needs. We're all working in service to him and what his medical, his behavioral health, and his social and family support needs are. We would be working with him to address his insurance status. Perhaps he is insured, we don't know, but that is a work that community-based organizations do all the time and that they would do for Marcus. If transportation is a barrier to him following up and keeping his appointment with his primary care doctor, that would be addressed. We would be connecting him to primary care under the auspices of a patient-centered medical home. We would be linking with hospital partners if we needed to, if he needed specialty care services, and then community services in particular, where we would be looking at home health care if he needs translation services and access to mental health providers, a whole other host of services. And if we did that all together with community-based organizations, again, sort of leading this charge as the first face, if you will, of a lot of this work to Marcus, we would translate his current state to a target state. So with his family history of colon cancer, no recollection of screening, we would embark on care management and activation that fosters completion of screening. So we would actually link him to screening services so that he can actually be aware of his risk. Delay in primary care follow-up, again, through care management and activation, we would foster consistent primary care follow-up and adherence to his medication regimen because he reported that he takes his blood pressure pills every now and then. He has child care responsibilities that may be impeding his ability to access services. So again, with care management and activation, we would foster connectivity to child care and respite care so that he could be given time to keep his appointments with his doctors and access other services that he may need as well. He has limited money to cover his basic living expenses. So again, through care management and activation, we would enable an assessment of his eligibility for benefits and navigate and link him to those benefits. With his unknown health insurance status, through care management and activation, we will be able to assess his eligibility and navigate and link him to health insurance or nominally priced or free primary care and care management services for individuals who are uninsured and uninsurable because they're undocumented in particular. And then for language, because language may be a barrier to him accessing care, treatment, and support services, through care management, we would ensure that he has access to culturally competent education, media, and services. And so this is how DISRIP would enable chronic disease prevention for colon cancer. And so again, I just want to thank you for having me here today. I hope you got a little bit of clarity about what this monstrous thing called DISRIP is about. And feel free to write your questions during the panel discussion. Thank you.
Stay there. Thank you very much. Thank you. Okay, I would invite the speakers to come to the podium, and Dr. Vignesh would moderate the session for us.
Thank you, Dr. Salisu and Dr. Lee. It was an excellent session. Thank you to all the speakers. Very, very important session. I have a lot of questions. I'm sure all of you have questions. If I can start off the questions, all of you can feel free to respond with your perspective, but I think specifically to Ms. Nicole Jordan Martin and to Ms. Elise Collins, if you can comment from your perspectives. I think all these principles you outlined are fantastic. It seems like you've thought through all the steps and the processes to connect the dots. You know, from the community centers, primary care, to hospitals. I just would like to hear a little more on the mechanics of how you're connecting us and the personnel who are required. You know, that was a very good example. For example, if we have a lot of patients with language barriers, we have sub-communities, you know, where it's difficult to do outreach with a language barrier. You have transportation issues. Of course, we have a lot of uninsured. To me, you need a liaison between the community and here, and you need a patient navigator within the system. But I would like to hear your thoughts on how you're going to help connect these dots.
Sure. So that is actually a great question. So it's really, you know, what are the mechanics for mobilizing, you know, such a large partnership of organizations who've come together and say that we want to work. And so I can give you an example in terms of a few of the interventions and how we get community and primary care to link. So one of the interventions on the district is that targets the uninsured and low and non-utilizing Medicaid population, which we call fondly Project 11, but it's really around activating, outreach and activating this population to link them to primary care and health insurance. And so when we looked at, you know, who will be the facilitators of this work, looking at working with healthcare plans, working with the state health information exchange and those navigation programs, and then working with the community partners in their specific settings, whether they're a hospital, emergency department, or they're in an inpatient setting or an outpatient or just a community-based organization, who's really doing that. So we have plenty of folks doing navigation and advocacy, and those are the roles that are envisioned to take responsibility for sitting with someone, asking them these questions about their health insurance status and their eligibility, educating them, and then the linkage. So this navigation person is responsible, if they're not insured, to link them to the Health Information Exchange navigation program. And again, if you're not insured but you're eligible, you are going in that direction. If you're not insured and you're ineligible because you're undocumented, is to link them to other resources that provide primary care, federally qualified health centers in particular, other organizations that may have fee schedules, very nominal fee schedules that they've created, such as New York City Health and Hospitals. There's something called HHC options, which allows individuals to access services at a very nominal cost. And there's also the linkage to primary care. And by linkage, we don't mean just referring people. We know that one of the reasons people don't make it and make the connectivity is that we leave them to navigate and at their own devices. And that's very challenging for them. So it's really about not just saying, I want to refer you here and refer you there. It's actually making an appointment and facilitating access to transportation and facilitating follow-up to make sure that they actually get to that appointment that you've made, including with their primary care provider. So those roles can be called anything, any number of things today. They're navigators, they're health educators, they're community health workers. It's whatever roles an institution wants to utilize to do this work.
Thank you. Do you have any comments, Ms. Collins?
I think the only thing I would say is, unfortunately, those people take funding, and so that's always a barrier. So all around the country right now, people are trying to make the case for the cost effectiveness of health workers and navigators, et cetera. There is, right now in New York City, I'm not sure if it's still open, but there's an RFP out right now for patient navigators for breast and colorectal cancer screening. So there is, the state and the city do understand that funding is an issue, but in trying to demonstrate the value of these type of positions, we are working to try to provide different funding opportunities for community health centers, FQHCs, and other practices to get these staff in there to help support these activities.
I think we can have a follow-up discussion specific to our institution, but I'd like to ask the opportunity Dr. Lee to.
Hi, I'm sure Dr. Vignesh and I share the same problem. We are actually very interested in providing colon cancer screening. The FIT test is a cheap way of doing it, but our challenge, even with patient navigators, is that if the FIT test is positive, how do we get them to the colonoscopy? And their options are very limited. If we do a FIT test, then the DOH-sponsored test will not provide patients with a colonoscopy. So actually, right now, our triage is if you have no insurance, we send you to the local place that will do it. So it has to be a referral, because if we do a FIT test and it's positive, they're rejected from that service. At a minimum, we do a fee schedule, and but it costs $1,000 out of pocket to do a colonoscopy. This is a rough estimate. You can't get the exact cost, but that is what it's cost. So even with patient navigators, bilingual patient navigators, we routinely have no-shows if they have financial assistance, and that's full financial assistance. So I'm just making an observation that, and I'm not even getting to if they have a colon cancer. How do they pay for the surgery? How do they pay for the chemotherapy? And I would be very interested in what the state is doing for that support.
So you're talking about the specific for the cancer services program. If they have a positive fecal test, then the diagnostics won't be covered. If they're not, if the fecal test is outside of the, I'm just trying to, I'm sorry, I'm not that involved with the direct services portion of our cancer services program. Mm-hmm.
That center, if you have a positive FIT, you are excluded. So we don't even offer them a FIT test, because then it's diagnostic colonoscopy. So we tell them if you have no money and you can't afford the $1,000, which we offer, we only have a rough estimate, that you should go to this other medical center and ask for a FIT test. So that is our current triage policy. And we are still struggling within ourselves, you know, if you get colon cancer, then the cost of surgery is even higher. And if you have stage 2 or some stage 2 or stage 3, you have the cost of chemotherapy. And we're not sure what the resources are to support somebody? I mean, can we get emergency Medicaid? Will that support it? I just need to be educated.
Sure, and with the Medicaid cancer treatment program that I mentioned earlier, that was started, it was started as sort of an add-on to the a national breast and cervical Medicaid treatment program that's national. And with the breast and cervical cancer program, you don't have to be diagnosed by a cancer services program provider to be eligible for that program. With colorectal, because that's just for our state, the way that program was created was that those you need to be diagnosed by a cancer services program credentialed provider. We are working and we have proposed that every year to get that legislation changed to make it so that you can be anyone diagnosed in the state. And Alvaro, you may have something more to say about what ACS is doing.
Can I just
also ask District Representative comment on that? Your problem is magnified 100-fold where we are. Yes. So, I thought that's what the funding should be for, the $6 billion. So how do we agree with that?
Sure. So the funding is not to fund the delivery of care. That opportunity continues the way it does today. You provide services and you get billed. The funding is really aimed around restructuring the way that we design and deliver those services and work together as a continuum of partners to make sure that we're creating an integrative delivery system that is meeting all the needs of a patient across the care continuum. Direct service delivery is reimbursed as is today. This is really about providing infrastructure and resourcing infrastructure to be able to provide services in a much more meaningful way. But it's not covering the cost of actual clinical services. It's really covering access to the navigation and linkage. So for that particular piece of it, the way that we would fund that work is community-based organizations can contract with us to do this navigation and linkage work under the rubric of Health Home at Risk, or the Project 11, where you're activating and linking
individuals to insurance and primary care.
Can I just add?
We have additional questions.
We have a very complicated healthcare system with a lot of holes in it. So this is something that we have identified, and we have been advocating for this. American Cancer Society has advocacy teams in the city council, legislature in Albany. We need testimonies from providers that this is an issue. So I'd like to talk to you afterward because I like to enlist your support. Your voice has a lot of power and influence, the voice of clinicians. So I think we need to talk about this because this needs to be addressed.
Okay. Dr. Vincent.
Good morning, Miriam Vincent, Medical Director of Ambulatory Care and Executive Director of Healthcare Innovation in District here at SUNY Downstate. State University of New York, University Hospital of Brooklyn should be really proud. I want to talk about our two initiatives. First, let me say it's been a wonderful, wonderful experience so far to have worked with One City Health. It's really been just wonderful. We have many of our leaders here and workers that sit on the committees. We're the major partner in the Brooklyn Hub. So first I want to talk about the patient activation measure. Well, folks who are here that have been working in patient activation measure, please stand up. We just started a couple of weeks ago. Come on, our nurses, Miss Marshall, our students, our patient access folks. We just started last week on the patient activation measure, first reaching out to our patients with no insurance, different settings, both in hospital access, the emergency room, or outpatient settings. And this morning, we were just setting up with going over to Midwood to go out to our health fair that our nursing educators, Ms. Young and Ms. Marshall, work with, and our nursing and public health students from Hunter. So we've really been reaching out. In a week and a half, we have more than 100 patient activation measures, so we have a better idea of how to approach our patients and hook them up with the services. And I will say this about SUNY Downstate. There has never been a time when and I've been here for 34 years, and I'm an MD, PhD, JD, doctor and lawyer, when we have had a patient, and I come from family medicine, with a positive stool guaiac or fit test, where somebody from GI somebody in the hospital has not gotten us emergency Medicaid, some kind of help, and gotten colonoscopy and treatment for that patient. Because that's what we're about in Brooklyn. If we can't prevent disease and we can't deal with patients, I want to know why we're here. Because we're educating the physicians and healthcare workers of tomorrow. This is our job, and we have to find a way. District gives us, while it doesn't directly pay for this kind of stuff, there's still dish monies. There's never a reason to not reach out to a patient and get that patient the care they need. So sometimes primary care takes the hit. Hey, that's the way it is. GI takes the hit. But that patient's going to get the care they need. We work closely as a team. More and more, we're a level 3 medical home. We've been that way, and our job is to take care of patients and to educate the healthcare workers of tomorrow. And is it easy? No. Do we deal with patients who have huge socioeconomic status issues and big-time insurance and health issues, both behavioral and medical? You bet we do. But that's what we're here for.
It's great,
Okay.
Dr. Vincent, that we have, and we have all of you. I think all of us need to get to know our district team and all their roles, which would be very helpful to everybody. Who has the next?
Let me just
Doctor-
have a follow-up.
Okay.
So the follow-up is that we do offer the care, but because of the cost, they opt not to take it.
We're giving the care for nothing if we have to. We get dish monies, and that's what State University in part is about. We're part of the healthcare net, okay? Folks who have big-time either behavioral health problems or socioeconomic problems, they don't rise to the top of society. They're not the folks who run around with money in their pockets, but they're the folks who need more health and put a burden on our healthcare system. And I think all of us have to absorb that. If I call Vignesh and that patient, he's head of GI, and that patient's got a positive stool whack or there's any issues, he's going to make sure that patient has colonoscopy. We work with our finance and our healthcare access folks. And you know what? That's why the state pays us. So, you know, all of us bear this responsibility. All of us work with patients. It's how you step up to the plate and work together to take care of that patient. And we should also be very proud. We have our first 2 navigators who are here and working with patients. So there's new healthcare workers. How do we, as medical educators and community providers, as well as our specialists, all work together to best take care of the patient? And you just, you know, it's what you have to do. That's why we're here.
Thank you.
We have to move on to the
Thank
next
you,
question.
Dr. Carruthers. Thank you.
I appreciate those comments, so I'll mention a couple of things. So one, this is not, even though I'm in Michigan now, in Michigan I spent 15 years in California, so we have the same issues in California about coverage of screening tests by the state. They would cover mammograms, they would cover PSAs, even though PSAs have a questionable history now, but they wouldn't cover screening tests for even a FIT or a FOBT. So that hopefully has changed since I left the state of California. The thing I want to really, and by the way, there's going to be an editorial coming out in the journal Gastroenterology about the difference between screening and diagnostic colonoscopy and the payments for that. So someone wrote an editorial that I saw, so it should come out in the next couple of months. The real question I want to ask, this DSRIP, so I had 2 pieces to that. So over the last few years, University of Michigan and several other places were involved in the Medicare demonstration project, which is now evolved under the ACA into an accountable care organization. And we run 2 at the University of Michigan, and there's a number of these throughout the country. And accountable care organizations are entities that look to contain costs for the whole continuum of care. So I was just wondering, so is DSRIP really a New York State ACO? So that's question number 1. Question number 2, as part of that, this money is allocated by the state of New York, or where does this money come from? Because I don't think you mentioned that. And then thirdly, if that's true, so how has the ACA and the ability to get some percentage of people insurance, how does that affect DSRIP payments? So in other words, if they're insured, does that count, or is DSRIP really an ACO and they're in it or out of it, depending on if they get insurance? I don't know if you can answer that question, those questions.
Please try to keep your response brief because we're running short.
Sure. So Distrip is not an ACO. As I said, it's a 5-year opportunity for us to restructure and address a lot of the dysfunction, the systemic dysfunction of the way that we design and deliver healthcare services in the state. And so whether you're insured or not does not impact payment. Payment is based on some process, meeting some process milestones around, again, design, building infrastructure, and creating these partnerships so that we're better able to help patients link and navigate to the services that they need. And then starting in year 2 and then increasing significantly in years 3 to 5, it's about payment is based on performance and performance evidenced by outcomes, health outcomes. So it's about impacting, emergency room and inpatient utilization, but also impacting health outcomes of the population that's attributed to us. The money comes from a combination of the state as well as CMS. That's where the money for Distrip is coming.
So very similar to the goals of the ACO, but short-term.
Yes, and so the end goal of Distrip, when I said in my presentation, we hope to create sustainability of this transformation through managed care payment reform, is that by the 5th year, 2020, our responsibility is to morph ourselves into a very tightly knit integrated delivery system that gets paid for performance on, again, managing the health and well-being of a population and impacting their health outcomes. Which will be dramatically different from the way that we get paid today, which is transaction-oriented and fee-for-service.
So one last quick question.
Thank you very much for the presentation and for the explanation. The question that comes up is, we performed a community needs assessment, and SUNY Downstate at this point needs about 5 navigators and about 5 community nurses. Who's going to pay for it? That's the infrastructure that we need right now to provide better services and better access to our patients in the community. Can we apply for money from One City Health or Distrip?
Sure.
So we can get money right now to build the infrastructure, or we have to build the infrastructure first and then get money?
So that's also a great question. So the contracting that I mentioned around particular projects, so remember Distrip has some guardrails about what we use the money to support, including what particular disease states that we focus on. The guardrails really are around making sure that, again, we are focusing on infrastructure and transformation. And with the end result being better patient experience, improved health outcomes. And so the way that we would flow money, if you will, to partners is we would say this is the design for this project. So I'll give you an example. We have another project called Asthma Home-Based Management, and that design for that project includes the introduction of a community health worker role as part of the clinical team that addresses that patient in any clinical setting that they're encountered. So the question is, where would the community health worker role come from? And so for a project like that, we would give infrastructural support, so because you need your community health worker, so there would be money to fund that role and the introduction of that role to the team. And then there is also money for how that role is organized to work with the team to impact the intervention, which is really around doing an assessment of home environmental situation and triggers for asthma and facilitating remediation. So there would be payment for the community health worker, there would be payment for the number of home health assessments you actually get done, and with remediation, payment for the outcome of that, which is less asthma exacerbation and less emergency room visit and inpatient stays.
Okay.
Thank you all for an excellent session. Look forward to follow-up discussion. And
Thank you very much.
Thank you.
Thank you. We have a pledge, and the pledge is going to be made by the American Cancer Society. So Latoya, please come up. Let's do the pledge. We want by 2018, 80% of the population be screened. So let's make the pledge.
Good morning, early afternoon, everyone. I wanted to thank you all for having us here today. I want to acknowledge my colleague Lauren Moore, who's the Health Systems Manager with the American Cancer Society. She works closely with SUNY Downstate, and of course, Dr. Alvaro Carrascal. I am the Senior Manager for Primary Care Systems with the American Cancer Society. And earlier today, you heard Dr. Carrascal present about the 80% by 2018 pledge. We share a commitment to eliminating disparities in access to care. As such, our organizations will work to empower communities, patients, providers, community health centers, and health systems to embrace these models and develop the partnerships needed to deliver coordinated, quality colorectal cancer screening and follow-up care that engages the patient and empower them to complete needed care, from screening through treatment and long-term follow-up. Today, the American Cancer Society would like to publicly recognize the Brooklyn Health Disparities Center, SUNY Downstate Medical Center, and Arthur Ashe Institute for Urban Health, and the Brooklyn Borough President's Office as our newest partners to join the 80% by 2018 campaign. And what better way to do this than during Colorectal Cancer Awareness Month?
We all will do what it takes, what is necessary, in the community, in the hospitals, all the social services, all different activity issues to make sure that by 2018, 80% of our population is well served with screening colonoscopies. That's what we're all about. Thank you very much.